Okay. And my sincere thanks to the organizer of BT Echo 2021. And I'm going to speak on echocardiographic evaluation of aortic regurgitation. Now, when we do the echocardiography in a patient of aortic regurgitation, other than identification of the AR jet, which we can see as a very bright colored blue jet coming out of the aortic valve, we also try to get the answer of few questions. Can you see my slide?
Yes, ma'am.
Okay. So we try to find out the etiology of the aortic regurgitation. We try to quantify how severe is the disease, and also we try to see the hemodynamic consequences of aortic regurgitation on the heart, because answer of these questions will guide us for the line of treatment of the patient. Depending on the answer of these questions, we are going to decide whether we will continue with the medical follow-up of the patient, or we are going to send the patient for the aortic valve replacement to the surgeon. So as soon as we get a patient of aortic regurgitation and we start doing the echo, we start thinking why this valve is leaking. Is the aortic regurgitation is due to abnormality in the valve leaflet, or is it due to the abnormality in the root and the ascending aorta? So basically, we try to find out the etiology of the AR, because it is the key to the surgical plan. Surgeon has to plan depending upon the etiology of the valve. We need to look at the aortic root in the ascending aorta very, very carefully, because we get a lot of clues regarding aortic regurgitation from this area. And we need to look at the aortic valve also. Normally, there are three cusps: right coronary cusp, left coronary cusp, and non-coronary cusp, with a central line of closure. And when there is abnormality in the valve leaflet, either due to acquired heart disease or due to congenital heart disease, we get the AR. Here is a congenital heart disease, which is the bicuspid aortic valve, is the commonest congenital cardiac anomaly, and we may get aortic regurgitation. As you can see, it's an eccentric jet, and there are two cusps in the aortic valve. And when you get aortic regurgitation in a bicuspid aortic valve, it's extremely essential to look at the aortic root in the ascending aorta, which may be dilated because of the aortopathy in a case of a bicuspid aortic valve. Very rarely we may get a quadricuspid aortic valve. You see, there are 4 cusps in the aortic valve, giving rise to the aortic regurgitation, which is its commonest complication. And we also get aortic regurgitation in a case of VSD. Has resulted in malposition of the cusps, resulting in AR, and that AR causes further trauma to the other cusps and increasing the severity of aortic regurgitation. There is the AR in this case. And when we look at the acquired heart disease, as in the case of rheumatic heart disease, there is AR, and aortic regurgitation in rheumatic heart disease occurs along with the involvement of mitral valve usually. Here you can see the mitral stenosis also. We may get aortic regurgitation in infective endocarditis. As you can see, there is a large vegetation in this bicuspid aortic valve, giving rise to the severe aortic regurgitation. And also we may get aortic regurgitation due to abnormalities in the aorta. One such abnormality is annulo-aortic ectasia, where there is a huge dilatation of the aortic root and the ascending aorta, which we may get in connective tissue disorder like Marfan syndrome or Ehlers-Danlos syndrome. Here the dilated root stretches the valve apart and the cusps cannot meet, giving rise to the aortic regurgitation. And also our AR is present in aortic dissection. As you can see the intimal flap, and look at the aorta, it's hugely dilated. So the cause of AR in a case of dissection of aorta, maybe various, like in this case, there is dilatation of the root with leaflet tethering. It might be due to the disruption of the commissures from the wall or prolapse of the dissection flap, or there might be pre-existing aortic valve or aortic root disease. Other than these abnormalities, anatomical abnormalities, we get certain indirect signs of aortic regurgitation, like diastolic flutter of the anteromitral leaflet. Look at this eccentric jet of air. It's hitting the anteromitral leaflet in diastole, and that has given rise to the diastolic flutter of the AML. We get enlargement of the LV in chronic AR. So we need to look at the size of the LV, and also, initially the ejection fraction is normal, but subsequently there is a decrease in contractility and resulting in the reduction of the ejection fraction. So other than the size, we also need to look at the ejection fraction by modified Simpson's method. However, LV is not dilated in acute aortic regurgitation. Here the LV is unadaptive, unprepared, and patient goes into pulmonary edema very, very quickly. So this is such a case. You see, there was acute AR due to the trauma in the right coronary cusp. This is the transthoracic view, and this is transesophageal view, giving rise to this torrential aortic regurgitation happened in the cath lab during a procedure. Look at the LV. This LV is not dilated, but the patient went into pulmonary edema immediately. Whatever is the cause, whether it's in the aortic valve or in the root or the ascending aorta, assessment of the severity of aortic regurgitation done under the three headings of qualitative, semi-quantitative, and quantitative method. Now, each heading has got several parameters, but we must remember that we never stick to one heading or one single parameter. We need to look at all the parameters. At the same time, we must remember that all the parameters in each of these headings may not move in the same direction with the same intensity. All the parameters may not indicate you towards the severe. Some may indicate towards the mild or even moderate. So what we do, we pick up the parameters which are moving in the same direction, maximum parameters moving in the same direction, and we comment on the severity of the aortic regurgitation. So when we go for the qualitative assessment of the severity, we look at the structural parameters as well as at the Doppler parameters. While looking at the structural parameters, we look at the LV size, which is usually dilated in chronic severe aortic regurgitation. And if you look at the aortic valve leaflets, in the severe AR, it is usually abnormal, as in this case, there is a perforation in the non-coronary cusp, and you can see there is a coaptation failure giving rise to the severe. And in mild case, it is either normal or mildly abnormal. But this type of coaptation failure and leaflet indicates towards the qualitative Doppler parameters in the parasternal long axis with the color flow. We must remember that we never look at the length of the jet of aortic regurgitation. We never look how long it is extending into the LV. We look at the AR jet only in the LV outflow tract. So what are the things we are going to look at? We are going to look at the width of the jet. You see, this is the width of the jet in the parasternal long axis and the LVOT. If you look here, it's only a small central jet indicating mild AR, whereas here in this case, there is a severe large central jet or large eccentric jet. These indicate towards the severe aortic regurgitation. We also look at the density of the AR jet by doing CW Doppler in the apical 5-chamber view. You see, this is the aortic regurgitation. We make the cursor parallel to the AR jet, and then we get the CW Doppler. This is the signal CW of the CW Doppler. Above the baseline is the aortic regurgitation. We look at the density of the jet. In mild aortic regurgitation, it is faint, or even it might be incomplete. Whereas look at this severe aortic regurgitation, quite dense signal. So higher the density of the signal, more significant is the regurgitation, because more blood cells are going out of the aortic valve into the LV, so the density is more in severe AR. We also look at the jet deceleration slope in that same CW signal from the apical four-chamber view. That we look at this slope qualitatively. In a mild AR, the slope will be slower. Look at the pressure half time. It's 508 millisecond. Whereas in this particular case of severe AR, look at the slope, it's quite steep with the pressure half time of 201 millisecond. And also we look at a very interesting finding in aortic regurgitation. We look qualitatively at the diastolic flow reversal in descending thoracic aorta from the suprasternal view. So this is the suprasternal view. This is descending thoracic aorta, transverse arch. Normally, this flow goes from above downwards, so there should be only blue flow. Look at these. There is a red flow, which indicates the flow reversal. But if it is for brief period in the early diastole, it indicates mild aortic regurgitation. Whereas look at this patient. There is severe pandiastolic flow reversal in the descending thoracic aorta. Look at the red color. It's occupying the entire diastole. However, looking at the flow reversal may be difficult to appreciate how long of the diastole is occupied by the flow reversal. So for that, again, we have some other qualitative method, like doing an M mode through this descending thoracic aorta. We pass the cursor, get the M mode, so this gives the color M mode. Here is the end of T wave, so this is end of systole. Blue color indicates systole. The red is the diastole. If you look at this is the entire period of diastole. Look here, it's only in the early diastole. So also in the pulse wave Doppler signal, it's only in the early diastole. So it indicates mild AR. Whereas if we look here in this next patient, where there is severe diastolic flow reversal in the descending thoracic aorta, and I do the M mode. Look at the diastole. Entire diastole is filled up with the flow reversal. So it's a hollow diastolic flow reversal indicating severe aortic regurgitation. So also the pulse wave Doppler signal, the entire diastole is occupied by the flow reversal. So after this qualitative assessment of severity of AR, we go to the semi-quantitative parameters. Again, we have three parameters under this heading: vena contracta, jet with LVOT with ratio, and jet cross-sectional area, LVOT cross-sectional area ratio. So let us start with the vena contracta. As we know, the vena contracta is the narrowest neck of the regurgitation jet. So what do? We go to the parasternal long axis view and put the color flow. And you see this is the regurgitation. The entire LVOT is occupied by the aortic regurgitation, but this is not vena contracta. Vena contracta is just below the aortic valve, but the flow continues to narrow, you see. So we freeze and then we measure the vena contracta, where still it is narrow. Here is the aortic valve. It's just after the aortic valve in the LVOT. So here, the vena contracta is 0.8 centimeter, indicating the severe aortic regurgitation. But look at this next patient. We measure the vena contracta and we find it 0.3 centimeter, which indicates mild. So this is the semi-quantitative measurement of aortic regurgitation. Another such semi-quantitative measurement is the ratio of AR jet with an LVOT with ratio, and we do the percentage of that ratio. So what we do, we go to the parasternal long axis view, and then we freeze the image, and we then measure the jet height just on the 1 centimeter of the VC towards the LV side. So if this is the vena contracta, it should be within 1 centimeter of the vena contracta, and the LVOT height also is taken at the same cross-sectional level. We never go this side or that side. Wherever we may measure the jet width, we measure the LVOT width also. And here in this case, the ratio is only 22%, which indicates this regurgitation is mild. On the other hand, look at this jet. It is occupying the entire LV outflow tract, and we find that the ratio is 85%, which indicates the aortic regurgitation is severe. And while looking at the eccentric jet, this semi-quantitative method measurement is not useful. This has a pitfall, because you see in this particular eccentric jet of aortic regurgitation due to bicuspid valve, if we look properly, the jet is originating somewhere here near the, it's much more anteriorly towards the RCC level, and then it courses down along the aortic valve. Often it gives a false impression of severe, and moreover, we really can't measure the vena contracta and the jet height here, because it's running, perpendicular to the LVOT. So the measurement of the vena contracta, jet height, and LVOT height laterally is not allowed. We cannot measure like this. We need to measure vertically. So this type of semi-quantitative measurements are not done in eccentric jet of aortic regurgitation. We follow the other parameters for quantification. Another is the cross-sectional ratio of the cross-sectional area of AR to the cross-sectional area of LVOT. So what we do, we go to the parasternal short axis view, put the color flow. This is the aortic regurgitation, that small jet. We remain slightly towards the LVOT, and then we freeze, we zoom the view, and then we measure the jet area, and then we measure the LVOT area, take the ratio. If it is more than 60, then it's severe. If it is less than 5, it's mild. So next to that, we will move to the quantitative assessment, again under the headings of regurgitant volume, regurgitant fraction, and effective regurgitant orifice area. These are the 3 parameters. Now, we always do the quantitative assessment of severity of MR, but we have a habit of not doing quantitative assessment for AR, but which we should do regularly. And if we do regularly, then we become expert in it. So, and it's not very tough. We don't usually we do not follow the PISA method. Rather, we will use the stroke volume. So, because you see, regurgitant volume is obtained from a stroke volume across aortic valve minus stroke volume across a competent valve.
Madam,
which might
1 minute left.
Okay. I'll wrap up. So, and regurgitant fraction, once I get the regurgitant volume, regurgitant fraction is obtained by dividing regurgitant volume with stroke volume across aortic valve, and ERO is obtained by dividing regurgitant volume with the VTI. So we need to have 3 things: stroke volume across aortic valve, stroke volume across a competent valve, and a VTI of AR jet in 5 chamber. So here is a patient where we have measured the stroke volume across the aortic valve. You see, So as in the step 1, we measure the stroke volume across the aortic valve, 139, and then we measure the stroke volume across the mitral valve, measuring the mitral valve diameter across the annulus, and keeping the sample volume in the midpoint of interannular point. We do the pulse wave and take the VTI of mitral valve. We get 106. So 33 ml is the regurgitant volume. Once we get the volume, we can get the regurgitant fraction of 29%, and the effective regurgitant orifice area is obtained from the VTI of AR jet, which is 0.18 centimeters square. So if we fit here, our patient falls in this group of, you see, moderate. It's not moderately severe or severe. So this is the way we grade the severity of aortic regurgitation. And very important is to take the measurement of annulus in the mid-systole from the parasternal long axis view, and of the aortic root and the sinitibular junction and the proximal ascending aorta, because these are valuable. So here I come to an end of my talk. Thank you for patient hearing, and wish you a very happy 2022 in advance. Thank you.
Thank you, madam, for your brilliant presentation.